How was that?
Good. Perfect.
Hello, my name is Shervin Etemad, and I'm a third-year medical student at the Vanderbilt University School of Medicine. As the U.S. population ages, healthcare providers from across the spectrum will be challenged to consider the unique aspects of caring for older patients. We will all have to consider what interventions and care our older adult patients need, as well as which ones may be unnecessary and even cause harm. To address some of these challenges, the American Geriatrics Society has joined the Choosing Wisely campaign in releasing the following list. The work group that created this list includes group members from the clinical practice and models of care groups, ethics, ethnogeriatrics, quality and performance measurement committees, and geriatricians. Important contributions were also made by the American Academy of Hospice and Palliative Medicine. I hope you find this useful as you take care of your older patients. And don't forget, when in doubt, choose wisely. Number 1, don't recommend percutaneous feeding tubes in patients with advanced dementia. Instead, offer oral assisted feeding. A 1999 study of tube feeding in patients with advanced dementia showed that tube feeding does not prevent aspiration pneumonia, prevent consequences of malnutrition, improve survival, or even prevent or improve pressure ulcers. In addition, it doesn't improve functional status or improve patient comfort. Careful hand feeding for patients with severe dementia is at least as good as tube feeding for these outcomes. Tube feeding is also associated with agitation, increased use of chemical and physical restraints, as well as worsening pressure ulcers. Some alternatives to consider include, number 1, discontinuing non-essential medications such as those with anticholinergic effects, NSAIDs, or bisphosphonates, which may contribute to esophagitis. Reminders to swallow multiple times per bolus. Bolus sizes should be less than 1 teaspoon, and liquid supplements should be always considered. Number 2, don't use antipsychotics as the first choice to treat behavioral and psychological symptoms of dementia. Patients with dementia often exhibit aggression, resistance to care, and other disruptive behaviors. There is limited and inconsistent evidence that the benefits of antipsychotics outweigh the risks. Risks of antipsychotic use in this patient population include oversedation, cognitive worsening, falls, strokes, and increased mortality. Their use should only be limited to cases where non-pharmacologic measures have failed and patients pose an imminent threat to themselves or others. Some interventions to consider include assessing for presence of pain, reviewing new medications, validating that the person seems to be upset and reassuring them that you want to help, as well as separating the person from what seems to be upsetting them, speaking slowly and calmly in a normal tone of voice. And if you appear to be the cause of the problem, consider leaving the room and giving the patient some space. Number 3, avoid using medications other than metformin to achieve a hemoglobin A1C of less than 7.5 in most older adults, as moderate control is generally better. While metformin is associated with long-term reductions in myocardial infarction and mortality, the use of other medications to achieve tight control is associated with higher mortality as well as higher rates of hypoglycemia. Considering the long time frame to achieve microvascular benefits of tight control, targets should reflect patient goals, health status, and life expectancy. Some recommended A1C targets are here, and they include 7 to 7.5 in healthy older adults with long life expectancy, 7.5 to 8 in patients with moderate comorbidity and a less than 10-year life expectancy, and 8 to 9% in patients with multiple comorbidities and shorter life expectancy. Number 4, don't use benzodiazepines or other sedative hypnotics in older adults as first choice for insomnia, agitation, or delirium. Adverse events associated with benzo use in older patients include cognitive effects of memory loss, confusion, and disorientation, psychomotor effects of dizziness, loss of balance, and falls, as well as residual morning sedation. A meta-analysis of 24 studies of older patients receiving sedative hypnotics for insomnia concluded that while their quality of sleep improved, there was a statistically significant increase in adverse events, as shown here. The risk of motor vehicle accidents, falls, hip fractures, and hip fractures and death can more than double in patients taking benzos and other sedative hypnotics. The use of benzos should only be reserved for alcohol withdrawal symptoms or refractory severe anxiety disorders. The website www.deprescribing.org provides helpful resources and algorithms for deprescribing in adults. This includes algorithms for deprescribing antipsychotics, proton pump inhibitors, benzos, as well as antihyperglycemics. This graphic is an example of the deprescribing algorithm for benzodiazepines. Number 5, don't use antimicrobials to treat bacteriuria in older adults unless specific urinary tract symptoms are present. The prevalence of asymptomatic bacteriuria ranges from 20 to 50% in older adults in the community and long-term care facilities, respectively. Studies have found no adverse outcomes for older men or women with asymptomatic bacteriuria. Treatment with antimicrobials demonstrates no benefits and increased adverse effects. Screening and treatment are recommended before urologic procedures in which mucosal bleeding is suspected. As you can see here, a urine dipstick for leukocyte esterase and nitrites, along with microscopic examination, should only be considered in patients who have either acute dysuria in one of the following: a change in urine character, change in mental status, gross hematuria, or two of the following alone, or fever, leukocytosis, and one of the following: CVA tenderness, gross hematuria, new or marked incontinence, urgency or frequency, or a change in urine character and mental status. Number 6, don't prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse gastrointestinal effects. While some randomized controlled trials suggest that cholinesterase inhibitors may improve cognitive testing results, it's unclear whether these changes are clinically meaningful. Evidence is lacking for whether or not these medications A, delay institutionalization, B, improve quality of life, or C, lesser caregiver burden. Adverse effects include diarrhea, nausea, vomiting, bradycardia, and hypotension. If a patient is prescribed a cholinesterase inhibitor for dementia and there is no perceived improvement of cognition within 12 weeks, they should be discontinued. Number 7, don't recommend screening for breast, colorectal, prostate, or lung cancer without considering life expectancy and the risks of testing, overdiagnosis, and treatment. Some risks of cancer screening include complications from testing, overdiagnosis, and treatment of tumors that would have never led to symptoms. Several examples are highlighted in this slide. For prostate cancer, about 1,000 older men would need to be screened and 37 would need to be treated to avoid one death in 11 years. Number 8, avoid using prescription appetite stimulants or high-calorie supplements for treatment of anorexia or cachexia in older adults. Instead, optimize social support, discontinue medications that may interfere with eating, and provide appealing food and feeding assistance, and clarify patient goals and expectations with the patient and their family. While high-calorie supplements increase weight in older adults, there is no evidence that they improve clinical outcomes such as quality of life, mood, functional status, or even survival. Magistral acetate, for example, results in minimal improvements in appetite and weight gain with no improvements in quality of life or survival. In fact, it carries an increased risk of thromboembolism, fluid retention, and death. In patients taking it, 1 in 12 will have an increase in weight, and 1 in 23 will have an adverse effect leading to death. Mirtazapine is another example. It is likely to cause weight gain or increased appetite when used to treat depression. However, there is little evidence to support its use to promote appetite and weight gain in the absence of depression. Number 9, don't prescribe a medication without conducting a drug regimen review. In 2005, 4.3 million healthcare visits were attributed to an adverse drug event. 35% of outpatients and 40% of hospitalized elderly experienced an adverse drug event. Older adults consume 1/3 of all prescription medications in this country that are prescribed each year and comprise of less than 13% of the population. The treatment risk paradox of older adults is that while they have the highest risk of developing a poor outcome, they stand to benefit the most from the treatment. Risks can include adverse drug events, drug interactions, medication non-adherence, decreased functional status, as well as contribution towards geriatric syndromes. For these reasons, it is imperative that a medication review is considered before a new medication is started. An annual review of medications is an indicator for quality prescribing in older adults. A study performed at Vanderbilt identified inter-hospital transfer interventions that reduced length of stay as well as mortality. As shown in this graphic, medication safety was a significant component of this process. It is an important part of patient care, and older adults remain especially vulnerable to adverse drug events. Number 10, don't use physical restraints to manage behavioral symptoms of hospitalized older adults with delirium. Not only can they worsen agitation and delirium, but they can also lead to serious injury and death. Some alternatives to consider include preventing and treating delirium, identifying and managing conditions that cause patient discomfort, as well as environmental modifications to promote orientation and sleep-wake cycles. Frequent family contact is always important if possible, and discontinue or hide unnecessary IVs or monitoring devices. Avoid short-term memory questions to limit patient agitation. Pharmacologic interventions are occasionally utilized after evaluation by a provider at the bedside if the patient presents harm to themselves or others. Physical restraints should only be considered as a last resort, in the least restrictive manner and for the shortest time possible. Thank you for taking the time to learn about choosing wisely in geriatrics. I hope this presentation was helpful in understanding in the ways we can improve quality care for older adults. Consider printing out a copy of the Choosing Wisely criteria. And don't forget, when in doubt, choose wisely.